All right, we are going to get started here, and it is my pleasure to introduce Dr. Muna Sunni. I think most of you know Muna. She did her fellowship with us here in pediatric endocrinology, and she has now been on the faculty about a year and a half, and she's going to tell you about work that she started in fellowship and that she's continued now with Somali children with diabetes, work on disparities in care and trying to understand their diabetes and improve care in this population. Muna.
Thanks, Tony. Thank you for allowing me the opportunity to present Grand Rounds. I'll be talking about diabetes in Somali children in Minneapolis and St. Paul, Minnesota. I have nothing to disclose. I'll be giving a brief overview on the pathogenesis of type 1 diabetes. I'll mainly be highlighting some of the terms that are going to surface later in the subsequent slides. I'll also be talking about two of the studies that we've conducted in the Somali population here in the Twin Cities, and I'll share with you what we've learned from these two studies. And then finally, I'll give you a sneak peek on our most recent study that's currently ongoing. So first, we'll start with a little bit of a background on type 1 diabetes. As you probably know, type 1 diabetes is an autoimmune disease of heterogeneous etiology that is characterized by beta cell destruction. Beta cells are the insulin-producing cells in the body, and so destruction leads to insulin deficiency and then subsequent hyperglycemia. So how common is type 1 diabetes? The prevalence data that I'm going to show in the next few slides were obtained from the Search Diabetes for Diabetes in Youth study. It was published in Diabetes Care in December of 2014. For those of you who don't know the Search study, this is a multi-center study that was conducted in the US with the goal of estimating the incidence and prevalence of type 1 diabetes, or actually of diabetes in general, in individuals younger than 20 years of age. This figure shows the prevalence data of type 1 diabetes in 2001 on the left-hand side and in 2009 on the right-hand side. These represent the overall incidence of type 1 diabetes in individuals younger than 20 years of age. In 2009, about 1 in 500 individuals had type 1 diabetes. Interestingly, the incidence of type 1 diabetes has been increasing by about 2 to 5% per year worldwide. And the reason for that is not really known. So when we look at the prevalence of type 1 diabetes by sex, males and females seem to be equally affected. This is true except for in ages when we start getting up in the late teens and into adulthood. There tends to be a slight male predominance. When they broke the data down by age into age groups, although you can appreciate that children younger than 4 years of age can get type 1 diabetes, it's a lot more common as age increases, and it tends to peak in the peripubertal years. And it reaches a prevalence of 1 in 300 individuals by age 18, which I think is pretty striking. When looked at by ethnicity, non-Hispanic whites have a much higher prevalence of type 1 diabetes compared to all the other ethnic groups. They have a prevalence of about 1 in 400 individuals. That was followed by African Americans, and you can see how the prevalence declines in other ethnic groups represented in the Hispanics, Asian, Pacific Islanders, and Native Americans. Type 1 diabetes develops over a period of time. This can be months or years. we're all born with a certain amount of beta cell mass, and we're also born with different susceptibilities for type 1 diabetes. There are a lot of genetic risk factors that contribute to our risk for developing type 1 diabetes. And just having susceptibility to it doesn't mean that we automatically end up getting type 1 diabetes. So individuals who go on to develop type 1 diabetes at some point end up being exposed to some trigger, some environmental factor that is not known, that sets off the immune system and results in development of a T-cell mediated immune response and in subsequent injury to pancreatic beta cells. As a result, you have a decline in the beta cell mass, and you also end up with autoantibodies to the beta cell components. Again, this continues over a period of time, and it can be variable. During this time, there are no clinical signs or symptoms of diabetes, so it's subclinical during this time. But nonetheless, it is progressive and it's continuous, and eventually leads to appearance of type 1 diabetes when enough pancreatic beta cells have been destroyed. And that usually happens when about 80% of pancreatic beta cells had been destroyed by this immune process. At that point, you see the typical clinical symptoms of type 1 diabetes, the famous polyuria, polydipsia, and weight loss. From that point onwards, you can see that there's still some beta cells remaining, so about 10 to 20% of the original beta cell mass. And that is the honeymoon period. Again, there continues to be progressive destruction of the beta cells, eventually leading to complete loss of the beta cell mass and complete insulin deficiency, and therefore insulin dependency. So what is our immune system supposed to do? Our immune system is supposed to be able to recognize self from non-self antigens. This figure shows an example of the pancreatic beta cells where there are peptides from these beta cells released. They're taken up by antigen-presenting cells who present them to CD4 lymphocytes. Normally, this doesn't go on to activate the immune process further because the regulatory T lymphocytes stop that process and suppress that. In individuals with type 1 diabetes, however, there is a defect in that process, and this doesn't stop at this point. And as a result, you end up with the antigen-presenting cells presenting endogenous or self-antigens to CD4 T cells, which lead to activation of CD8 T lymphocytes that go on to attack the beta pancreatic cells. Also, not shown on this study, on this slide, is there's also activation of B lymphocytes that leads to generation of diabetes autoantibodies. So diabetes autoantibodies, they support the diagnosis of type 1 diabetes, but they do not cause it. Again, the process by which type 1 diabetes happens is a T-cell mediated immune response. However, their presence supports the diagnosis. There are several different types of diabetes autoantibodies that have been identified. There's islet cell antibodies, glutamic acid decarboxylase antibodies, the famous GAD antibodies. There are IA2 antibodies, insulin antibodies, and finally zinc transporter 8 antibodies. The first four are used in clinical practice as well as research. However, the last one, or the zinc transporter 8 antibodies, are the most recent addition to this group, and they're primarily used in research. So I talked earlier about genetic susceptibility to developing type 1 diabetes. As far as genetic susceptibility goes, there are a lot of genetic factors that have been identified to place the person at risk for type 1 diabetes. By far, of all of those risk factors or genetic factors that have been linked to type 1 diabetes, human leukocyte antigen, or HLA genes, carry the most important risk of all of those. They're the most important determinant of a person's genetic risk for developing type 1 diabetes. And as I mentioned earlier, just because a person carries those high-risk genes doesn't automatically mean that they're going to develop type 1 diabetes. So HLA genes are located on chromosome 6 on the short arm. There's class 1, 2, and 3 HLA genes. For type 1 diabetes, we're going to be talking about class 2 HLA genes. And as you can see, there's the HLA-DR genes, HLA-DQ genes, and HLA-DP genes. Each of these genes encodes a protein, and these proteins are expressed on the surface of antigen-presenting cells. Here in this figure, you see an antigen-presenting cell and a CD4 T cell. On the surface of the antigen-presenting cell is the major histocompatibility class 2 or HLA class 2 proteins. They're presenting an autoantigen to the CD4 cell through the T cell receptor. This figure highlights the strong association between HLA class 2 genes and type 1 diabetes in comparison with several of the other genetic risk factors that pose a risk for type 1 diabetes. And this list here is by no means exhaustive. So each of the HLA genes has a relatively large number of alleles. And because of that, there has been a very complex system of nomenclature developed over the course of years. It evolved over decades, but for the purposes of today's talk, I'll just mention that HLA alleles are expressed as HLA-DR-DQ haplotypes. Haplotypes is a group of genes transmitted together. Each allele in the haplotype plays a role in determining the risk posed by that particular haplotype. The high-risk alleles that have been linked with type 1 diabetes are primarily the HLA-DR3 and DR4 alleles. When they are present in the heterozygote form, so HLA, DR3, and DR4 together, that poses the highest risk for developing type 1 diabetes. Also, DR4 is high risk. HLA, DR3 is also high risk, and there's a number of other DR forms that have been described. I'm not going to cover those today. In Caucasians, most commonly, we'd see HLA-DR4 genes. Human leukocyte antigen alleles can be different in different populations. And that actually brings us to why I'm going to talk about Somalis in the next few slides. Before I talk about our studies, I'd like to give a very quick background on Somalis, which most of you would probably know already. Somalis are a group of individuals who originate in the East African country Somalia. The majority of them arrived in the US in the 1990s and early 2000s as refugees, fleeing the civil war that erupted in their home country, Somalia. They resettled in several countries around the world, primarily in Africa, but also in Europe, and also in the US and Canada. In the US, Minnesota happens to be home to the largest Somali population. And per the US Census Bureau data, there's roughly 40,000 Somalis. Now, this number is thought to be an underestimate by a long shot by many. So this change in the demographic profile in Minnesota makes it very important for us as healthcare providers to better understand this population so we can serve them better. So my co-investigators and I decided to study diabetes in Somalis for a number of reasons. First, because there's a relatively large number of Somali children in Minnesota with diabetes, and particularly type 1 diabetes. And to put this into perspective, our preliminary data from our study show that the prevalence of type 1 diabetes in Somalis was very similar to Caucasians, which is the highest of all the ethnic groups, as I'd shown you earlier. Also, data from a Finnish study done on Somali children with type 1 diabetes shows that the prevalence of type 1 diabetes in Somalis in Finland was actually similar to that of Finnish children. And many of you know that in Finland has the highest prevalence rate of type 1 diabetes in the world. So that is pretty impressive. Yet, despite that, very limited data is present in the literature on this topic. So we decided to change that. And finally, it's been well established that cultural factors play an important role in diabetes management in immigrant populations. And so understanding the cultural beliefs related to diabetes in this group could be potentially beneficial. So our first study in the Somali population, diabetes in Somali children in the Twin Cities, Minnesota, was done with the objectives of determining the diabetes autoantibody profile and the human leukocyte antigen types that these children with diabetes who are of Somali origin have. We recruited boys and girls with type 1 diabetes who are of Somali origin, who are 19 years and younger. Recruitment took place at the University of Minnesota, Children's Hospitals and Clinics of Minnesota, and also out in the community. We collected data from electronic medical records and by interview. And we obtained a venous blood sample from participants to check for autoantibodies and human leukocyte antigen types. We shipped our samples to the lab at the Barbara Davis Center in Colorado, which is a reference lab for several large-scale national studies on type 1 diabetes. Our comparison data were obtained from published data on children with type 1 diabetes from the Somali study that was done in Finland that I had mentioned, also from data obtained at the Barbara Davis Center on African American children whose families have been in the U.S. for generations, and also from Somalis in Minnesota who do not have type 1 diabetes. For statistical analyses, I used the mean plus minus standard deviations for our continuous variables, and for association analyses, used the odds ratio. So we were able to recruit 31 participants. It sounds like a small number, but again, to put this into perspective, this is the largest number of Somali children with type 1 diabetes that has been published to date. The only other study that had studied Somali children with type 1 diabetes had 12 participants. So this is twice as many kids as that study. The average age of our participants was about 13 and a half. Just over a third of them were female, with an age at diagnosis averaging about 6.5 and a duration of diabetes of about 4 years. All but 5 participants were born in the U.S. The 5 who were not born in the U.S., 3 of them were born in Kenya, 1 was born in Uganda, and 1 was born in Ethiopia. And these children had, on average, a normal BMI-C score. So the results for the diabetes autoantibodies in this group was consistent, showed that their antibody profile was consistent with type 1 diabetes. All 31 participants had at least 1 diabetes autoantibody. Insulin antibodies were the most common type of antibodies we found. GAD antibodies were present in 56% of participants. About a third had IA2 antibodies, and zinc transporter 8 antibodies were present in 1/4 of participants. When we excluded insulin antibodies, still 74% of participants had at least 1 other autoantibody type. A third had 1 autoantibody type in addition to insulin antibodies. A third had 2 autoantibody types, and 10% of participants had 3 additional autoantibody types in addition to insulin antibodies. And we know the higher the number or the types of autoantibodies present, the worse the diabetes. So the results on the human leukocyte antigen genes were also consistent with type 1 diabetes. They showed a predominance of HLA-DR3. Again, HLA-DR3 is high risk, and also as is DR4. This table shows the HLA-DR3, DR4, and DR13 genotype frequency in 30 Somali children with type 1 diabetes. So out of the 31, we were able to obtain samples on 30 Somali children. As you can appreciate, 28 out of 30 children with type 1 diabetes in the Somali group had HLA-DR3. So that's a whopping 93% of participants. That was followed by DR13, where just under a third had DR13, and then DR4, which is more common in Caucasians, was a lot less common in the Somali group, with only 13% or 4 participants out of 30. As I mentioned earlier, DR4 is more common in Caucasians, so in Caucasians, you'd probably see these percentages reversed. This largely agreed with the data from the Finnish study on Somali children with type 1 diabetes, where they also had a relatively high prevalence of DR3 genes, and they had, that was also followed by DR13 and a much lower predominance of DR4. This, however, was not the case in the African American children with type 1 diabetes that were studied at the Barbara Davis Center, where they had a much lower prevalence of DR3 genotype and a higher prevalence of DR4 genotype compared to the Somali groups. So at this point, the question that came up was, do Somali children with type 1 diabetes just happen to have a more aggressive, if you will, form of DR3 that places them at higher risk for type 1 diabetes? Or is this DR3 just prevalent in the Somali population in general? So we went back and we collected data on Somalis who do not have diabetes. We call them Somali controls. We were able to obtain samples on 49 participants. And similar to the two Somali groups who had type 1 diabetes, there was a predominance of DR3 genotype, again followed by DR13 and a relatively low prevalence of DR4. Additionally, association analyses showed that the risk of type 1 diabetes conferred by the DR3 in the Somali group wasn't any higher than that reported for African Americans. So that answered our question. And again, we learned that DR3 just happens to be a lot more common in the Somali population. So we concluded from this study that the autoantibody profile for Somali children with type 1 diabetes was consistent with type 1 diabetes, that their HLA profile was also consistent with autoimmune type 1 diabetes, and that they had a very highly predominant DR3 genotype frequency. However, the risk conferred by the DR3 alleles was not any higher than that in African Americans. So we'll move on to our second study in this Somali group. Understanding cultural beliefs in families of Somali children with diabetes in Minnesota. The objective from this study was to compare diabetes control in a group of Somali children with type 1 diabetes to their non-Somali peers, and also to describe the cultural and religious beliefs related to diabetes in this group. Our study sample was similar to that in the previous study. The comparison group for hemoglobin A1C levels was the non-Somali group that had a similar age, and they also had type 1 diabetes. Again, we collected data in clinic and from the electronic medical records. We obtained hemoglobin A1C levels on these participants. We averaged them over a period of time. And we administered a survey of 14 questions to these participants and their parents. The surveys were given to parents only if the child was younger than 12 years of age. The child was included if they were 12 or older. The surveys were 14 questions. 8 of them were multiple choice questions, and 6 were open-ended questions. They were both in English and in Somali, and they were given out in a particular language based on preference. For our statistical analyses, we used the student's t-test for hemoglobin A1C comparisons. This box plot figure shows the comparison in hemoglobin A1C levels between 25 Somali children with type 1 diabetes and 351 participants who have type 1 diabetes but are non-Somali. As you can see, the Somali group had a higher hemoglobin A1C on average, averaging about 9.5% compared to 8.8% in the non-Somali group. Just to give you a sense, so the American Diabetes Association goal for hemoglobin A1C levels is less than 7.5. And our clinic average of 8.8% is pretty much in line with what's been published nationally in other institutions. When we broke the groups down into those younger than 10 years of age and those 10 years and older, the difference disappeared. And the average A1C levels between the Somali and non-Somali group were pretty similar. Now in the group of 10 and older, the difference reappeared, and you can see that they had a much higher hemoglobin A1C on average than their non-Somali peers. So we'll move on to results from the surveys. So the majority of families seem to be coping well with diabetes, and just a small number of them seem to have concerns that were expressed. Less than 10% of participants believed that diabetes could have been prevented. 21% thought that they had coped well with the diagnosis of their children with type 1 diabetes. And 29% thought that their child wasn't any different than other siblings, and they thought that they were different than other children, and they actually disciplined them differently. The majority had a positive attitude towards the diabetes team, and 75% of them volunteered that they appreciated, most importantly, the diabetes education provided. Less than 10% of participants used additional remedies besides insulin in treatment, such as herbal supplements. Some used camel milk, some used garlic, black seed, but that was less than 10% of participants. Finally, 69% of them felt that there weren't any religious or cultural hurdles that would make diabetes management more difficult in this group. In the open-ended questions, a concern was brought up by several of the parents that there is a lack of resources to assist in carbohydrate counting in their traditional Somali foods. And many of you know that carbohydrate counting is one of the important aspects or routine tasks done in diabetes management. So we concluded from this study that Somali adolescents with diabetes had worse diabetes control, that the majority of Somalis seemed to cope well with the diagnosis, and they had a positive attitude towards the diabetes team, and particularly diabetes education, and then that there was a lack of resources to help count carbohydrates in traditional Somali foods. So in summary, so what we've learned from these two studies, again, was that diabetes in the Somali group was autoimmune in origin, and that they had an exceptionally high DR3 prevalence compared to others. However, the risk conferred by those DR3 alleles was not any higher than African Americans. While Somalis cope well with the diagnosis of type 1 diabetes, they had worse diabetes control. And then there was a lack of resources to help with carbohydrate counting in traditional Somali foods. So this brings me to our most recent and current ongoing study. development of novel pediatric diabetes education materials for Somali immigrants. This is a collaborative effort between the University of Minnesota, Masonic Children's Hospital, and Children's Hospitals and Clinics of Minnesota. This is Dr. Jennifer Kilo. She's my co-principal investigator at Children's. This study is funded by a grant from CTSI. So the objective from the study was to develop oral video-based educational materials for Somalis with diabetes. And, you know, any of you who have dealt with diabetes or any chronic illnesses know that managing a chronic illness is very challenging in any population when it comes to children. And this is a lot more pronounced in immigrant populations. They have a language barrier. A lot of them have low education levels. Some of them have psychological trauma from immigration. So there's a lot of factors that play into this. Also, there are some cultural factors that are important. And so the goal that we wanted to reach is to develop education materials that actually reach this population and are effective. We want to pilot these education materials on another group of Somalis with type 1 diabetes and see if that helps improve diabetes knowledge in this group with the ultimate goal of improving diabetes control. So our study design consists of 3 phases. The first phase consists of 2 steps. First, we developed focus groups, and this part has been completed. So the focus groups consist of the research team, that is endocrinologists, dietitians, diabetes nurse educators, and more importantly, the Somali families and their children who have type 1 diabetes. The goal from the focus groups is to ask parents and the patients what it is that they wanted to see in the educational materials that we were going to develop that wasn't already there. This is a picture of the Brian Coyle Center where we held our focus group meetings. This is a typical community room where we held our meetings. The second step in this first phase is development of Somali traditional food carb counting resources. This part is led by the dietitians primarily. Carol Brenzel, who's not in the audience today, but she has been spearheading this part. And also another dietitian who is Somali, Deka Farah, who is not part of the University of Minnesota, but has been a wonderful resource for us. This is a picture of a typical Somali lunch. It was actually taken by one of the medical students here at the University of Minnesota, Phil. We had this picture taken on one of the times that we went out to a Somali home to see how they prepare their traditional meals from scratch so we can help count carbohydrates and just get a better understanding of what it is that they eat. As you can appreciate, there's rice here, there's pasta, and there's a banana. As a provider, sees Somalis in clinic all the time, that never came up when doing any dietary recalls. It turns out that Somalis, when they have a meal, they very commonly eat a banana alongside with it, not later as dessert, just while they're eating their meal. And that's important because that's something they need to count the carbohydrates for in the meal. The other thing is the juice. So when they describe how much juice they drink, in our minds, we think juice, well, we'll just look on the box and see how many grams of carbs there is. That wasn't the case. This is a different kind. This is a powder kind of juice where they add sugar on top of it, making the carb content a lot more than what's on the box. And so not seeing that or knowing that before, you could very easily miscount carbohydrates. These are some of the other pictures that the two dietitians have taken while preparing some of the most commonly consumed Somali meals. We'll be putting them together in a nice resource that's mostly picture-based so that parents who have a literacy problem could actually find it user-friendly. So the second phase of this study is developing educational videos for Somalis. They're going to be in the Somali language. We're going to have children who have type 1 diabetes who are Somali be the actors in these videos. And we're going to try and make them as culturally appropriate as possible. So we're currently at this point in our study. Now, the third phase is we're hoping to pilot these education materials on another group of Somali children. We're going to do a pre and post knowledge test to see if that knowledge had improved. And along the way, we're going to be collecting hemoglobin A1C data to use as our secondary outcome. So stay tuned. Finally, I'd like to acknowledge the many people who've helped with the previous project and the ongoing project from the University of Minnesota Masonic Children's Hospital. I'd like to acknowledge Dr. Moran, who's been spearheading these efforts with her extensive experience in diabetes and in diabetes in Africans. Dr. Brandon Nathan, who's also in the audience, Dr. Bellin, who couldn't make it, unfortunately, and the two dietitians, Carol Brenzel, who's also not here, and Decca Farah. And also I'd like to acknowledge Dr. Aaron Kelly, because he's always been very helpful with his suggestions and thoughts. I'd also like to acknowledge the diabetes nurse educators, two of whom are in the audience, Anne and Marisa, and Shannon Beasley, who's not here. From Children's Hospitals and Clinics of Minnesota, I'd like to acknowledge my co-principal investigator, Dr. Jenny Kilo, and also Dr. Abu Zahab, who had helped out in the previous studies and was a co-investigator on those. We have wonderful students and research assistants and interpreters who've been crucial for any work we've been able to do in this group. And then we have our collaborators at the Barbara Davis Center and at Children's Hospital Research Institute in California, who have helped us navigate the HLA intricacies. And then finally, I'd like to thank the CTSI for funding our current project. And I'm happy to take questions. Yes.
Hi, I had a question. So you said 69%. Thank you. 69% said no cultural or religious difficulties with their diagnoses. And was the 31% all diet, or did you the carb counting, or were there any other themes that came out? Because it was nice that it was the majority, but it still caught me that 1 in 3 cited something. And then the follow up. Can you remind us if pork is used at all in any of the insulin regimens, and if that plays a role? And I can't remember. I think in med school it still did, but I can't remember now. So.
Great questions. So as far as the remainder who didn't think that there were any, or who thought that there were some hurdles, Ramadan came up a few times, and so some felt that managing diabetes during Ramadan was difficult, especially the older age group. Some just didn't have any suggestions as what they thought was the case. They just answered that as a yes. And so as far as the pork being in the insulin, it's recombinant DNA, and so no, there isn't any pork or porcine products in the insulin used. And thank you for being very culturally sensitive to that point, because it is a very big deal in this population, and it surfaces in other things like vitamins, for example. They very often ask me if there's gelatin, for example, in the gummy bears for vitamins, but no, not in insulin. Luckily, I'm glad there isn't. That would be a problem.
Thanks, Muna. That was great. I'm curious. Your study didn't really get at prevalence of diabetes in the Somali population, but do you know if the prevalence is higher among Somalis in the United States compared to those in Africa?
So we always wondered about this. I could not find any data. And, you know, part of this may be because, at least in Somalia, this may be true, because of the war that's still ongoing in Somalia, that they just haven't conducted such studies. I can't cite any numbers from studies in the neighboring countries where there is a large number of Somalis, but I didn't come across any when I was looking, you know, while working on this study. So the only prevalence data that I was able to locate was that from the Finnish study, and as you know, they have wonderful epidemiologic data, but that was the only study, and it had 12 participants with HLA data.
And then I have a second question, which is more practical. Do you find that the Somali population is using insulin pump versus injections similarly to non-Somalis, or?
So excellent point. So out of our group of 31 participants, 9 were on insulin pumps, and the remainder were on injections. And interestingly, there wasn't a difference in diabetes control between the two groups, which, you know, one would think that the group on the pumps would have done better, but they had very similar hemoglobin A1C levels. I'd say our non-Somali clinic population tends to have a higher use of pumps. So 70 to 80% of our clinic population are on pumps, and it was lower in the Somali groups. Yeah.
Do you have a sense of why that is?
So 29% of our Somali group are on pumps.
I understand. But
why? Why that is?
Why is there less adoption of the pump in that population?
So I
can imagine from several reasons, but what are your thoughts?
Yeah, exactly. I haven't studied it, and however, if I were to speculate on what I think is the reason, intimidation is one big factor, and the fact that there are a lot of things that that go into being on a pump, where you re-educate them all over again, that you worry about miscommunication during that process between the teaching person and the person on the receiving end. But we still offer them to all our Somalis. I just feel like they worry about having something attached, for one. They worry about being dependent on a machine. And they just get intimidated by all the buttons and, yeah.
I've done a little bit of work in sub-Saharan Africa, and diabetes is very difficult because insulin needs to be refrigerated, correct? And often refrigeration is not available. So these kids were all born here mostly, but did their parents have stories of family members or people they knew back in Kenya or even in Somalia? I mean, did they even not know? Was diabetes not even treatable, really? So maybe they didn't even recognize it as happening? Or
that's true. That comes up. Yeah, go ahead.
Yeah, no, I've just kind of related that. Like, what my experience is, it's unless you live right next to a clinic with a refrigerator, basically you die. You know, there's not much that can be done. So
funny you should ask. So. Two parts to the question. So the first part is, yes, it comes up all the time. Parents say, back home, we never had diabetes, that this is all because of Minnesota or the cold weather or something, or some, viruses. They always bring this up. And my answer to them is, we don't really know, because a lot of the kids there do die, and of unknown causes. So we don't know what the true prevalence of diabetes is in Somalia. The second part of your question, which is the fridges, I've co-authored a paper on insulin use and its storage in clay pots, and so where there is a lack of refrigerators, Africans have gotten really innovative about storing insulin. They store it in clay pots, and they're submerged in water, and it does keep the insulin relatively cool, and so they use those as their fridges. Yep. Thank you.